having described pharmacokinetics and pharmacodynamics, we come to a third topic related to our introduction of pharmacology, toxicology. Now, the word toxic means poisonous, but what we're really referring to here are the adverse effects, the bad effects that all drugs have. And the clinical principle that we've written here is that no drug has only one effect. It's essentially impossible that a drug has only one action on the body. So, first off, when we classify drugs, we have to classify drugs usually based on the most prominent or significant therapeutic action. Sometimes drugs are actually listed in drug books under more than one class or category because they're used for more than one purpose. As an example that we've just been talking about, antihistamines are listed in the treatment of allergies, but antihistamines are also used to help people go to sleep, and they're also used for motion sickness. So they could be listed multiple places in drug books. All the side effects or unwanted effects produced by a drug are called side effects. So when a patient is prescribed a dose of a drug, they try to give the dose that gives the greatest therapeutic benefit with the least amount of harmful or adverse effects. Here's some examples of what I'm talking about. So Benadryl is an antihistamine used for allergies, but it's also used as a sedative, as a sleeping aid. Iproniazide, you probably have heard of that. When you cover tuberculosis or TB, iproniazide is one of the drugs used as an antibiotic against tuberculosis. But it's also used as an antidepressant, interestingly enough. Amphetamines are CNS stimulants, but interestingly, amphetamines, including Ritalin and Adderall, are used to control ADD or ADHD. Attention deficit hyperactivity disorder, attention deficit disorder. Lidocaine. When you think of lidocaine, one thing comes to your mind, a local anesthetic. But in fact, if you mention the word lidocaine to a physician or a nurse, the first thing that comes to their mind is not a local anesthetic. It is, in fact, the most important cardiac antiarrhythmic used in the hospital. It's used to control electrical arrhythmias of the heart. Quinidine is used to treat, to control malaria, to reduce the incidence of malaria, but it's also used as a cardiac antiarrhythmic. Dilantin, or phenytoin, if I mention it, probably the first thing that comes to mind is it's an anti-epileptic drug, anti-seizure drug, but it's also used as a cardiac antiarrhythmic. So drugs can be used for more than just one purpose, is our point here. Now, there are different types of toxic or adverse effects. A toxic reaction is basically an overdose of the drug. It's when the therapeutic action, the positive beneficial action of the drug, when you take too much of it, it actually starts to become harmful. An example of that is digitalis. Digitalis is a drug used for, among other things, to slow the heart rate down. But if you take too much of it, it causes the heart rate to stop completely. It's called cardiac arrest. Heparin is used to reduce the incidence of blood clots for people who have an increased predisposition to strokes or heart attacks. Taking too much heparin, taking too much of any anticoagulant, Coumadin, Plavix, can cause hemorrhaging or spontaneous internal bleeding. Insulin. Insulin, of course, is given to lower the blood sugar level. If a patient takes too much insulin, they may fall to the floor because of low blood sugar level. Right? And so that's why you've been instructed that if you're told that a patient takes insulin and they faint in front of you, you've been instructed to give them candy. Is that right? Because it's possible that they overdosed on insulin, they lowered their blood sugar level too much and lost consciousness. Now there are all kinds of many drugs, essentially all drugs also have side effects unrelated to the therapeutic action. A side effect, and we mentioned this, of narcotic pain relievers is they cause constipation. Now, we actually said that in some cases, they actually take advantage of that. Lomotil, a Schedule V controlled substance, I said, was a narcotic a drug, but it's used for the purpose of decreasing GI motility for people with severe diarrhea. Tetracycline, very important antibiotic, can cause mottling and discoloration of the teeth. Phenytoin, the drug used, we mentioned, not only for anti-seizure, but cardiac antiarrhythmia, causes enlargement of the gums. Antihistamines generally have a side effect of causing drowsiness. And almost all CNS drugs, almost every drug affecting the brain causes xerostomia. That's the one I've said that if you're not sure what a side effect a drug might have, and it's on a case study question on the board exam, and they're trying to get at having you be concerned based on a side effect, guess xerostomia. It's going to be the most common thing. Drugs can also have local irritating actions, commonly at the site of absorption. So an example of a drug that irritates at its site of absorption is aspirin. We have learned that aspirin, acetylsalicylic acid, a weak organic acid, when you swallow it, it is absorbed across the stomach. And right where it's absorbed, it irritates the stomach. And because of this gastric irritation, when people have to take aspirin every day, regularly every day without end, they develop all kinds of gastric problems. Now you might say, well, you might ask, well, who takes aspirin all the time? Don't we take Tylenol today? Well, we tend to take Tylenol for pain relief, for headaches, but many people are taking aspirin, right, as an antiplatelet, anticoagulant every day, or they're also using aspirin for arthritis as an NSAID, a non-steroidal anti-inflammatory drug, and they take it every day. So they do tend to get gastric irritation. And there are many drugs that cause irritation. Another one is erythromycin. Erythromycin, we mentioned before, it greatly affects the intestinal tract, and almost anybody who has to take erythromycin more than a few days develops diarrhea and cramping. So it's just causing irritation in the digestive tract. There are many drugs that have these problems. On page B21, I'm sorry, so it's 19, yeah. Okay, another category on B21, very important, is allergic reactions. Now, allergic reactions, I prefer the term actually hypersensitivity. That's what an allergic reaction is. It's where somebody is overly sensitive to something that really should not cause a problem and doesn't cause a problem in most people. Now, of all the different adverse reactions of drugs, only allergic reactions are not dose-related. What does that mean? That means that with all the other adverse or side effects, the more you take, the greater the adverse effect, the side effect. But in the case of a hypersensitivity or allergic reaction, you're either allergic to it or you're not. So if you're not allergic to penicillin, if you take too much penicillin, it may have other various side effects, adverse effects, but you will never have an allergic reaction. It's not like if you took a little bit, you don't have an allergic reaction, but if you take more, you will have an allergic reaction. You either are allergic or hypersensitive to it, or you're not. So it has nothing to do with the dose. Now, some drugs are more allergenic than others. And what we mean by that is that more people tend to be allergic to some drugs than other drugs. The most allergenic, the drug that more people are allergic to than just about any other drug is, unfortunately, penicillins. And penicillins are important drugs. What proportion of the population is allergic to penicillin? It's approximately 8% of the U.S. population. 8% of the U.S. population. That's almost 10%. Almost 1 out of every 10 people is allergic to penicillin. I think I asked this before. Is anybody allergic to penicillin in this class? Nobody? All right, so that's unusual, because usually when I ask, at least 1 or 2 people in a class this size would be allergic. Now, besides penicillins, which is almost 1 out of every 10 people, sulfa drugs. And about 5% of the population is allergic to sulfa drugs. Anybody here know that they're allergic to sulfa drugs? Okay, we've got a very non-allergenic class. You might ask, well, what is a sulfa drug? So sulfa drugs are used for a couple of things. They include the antibiotics Bactrim and Septra. Those are sulfa drugs. Bactrim and Septra, those are antibiotics. It also includes, that's also related to a sulfa drug, PABA. Anybody know what PABA is? Paraminobenzoic acid. And paraminobenzoic acid, here's why you should know that. The ester local anesthetics are PABA derivatives. So anybody who's allergic to PABA, allergic to sulfa drugs, is commonly allergic to the ester local anesthetics. They are synthetically derived from paraminobenzoic acid. PABA is also used as a sunscreen, like in when you put it on your lips and so on. It's got PABA in it, or as a sunblock. There are some other drugs that are also tend to be pretty allergic, but those are the 2 most common. Actually, aspirin, about 5% of the U.S. population is allergic to aspirin. And aspirin's found in many things. Now, as far as the development of an allergic reaction, so you learned all about this kind of stuff, I think, in not only some of it in micro class when you covered immunology. More recently, you've covered some of this in your oral path class. But I'll just remind you a little bit about this, and I'll make a few comments, and then we'll show you a picture. What happens when you're exposed to something that you're potentially allergic to, and again, this is genetic. Whether you're going to be allergic to penicillin or not is genetically determined. And if you have a parent that's allergic to it, you're more likely to be allergic to it. But the first time you're exposed to the, let's say, the drug that you're allergic to, it doesn't have to be a drug, it could be anything you're allergic to. So when you're exposed to the drug, so let's say you're given the drug, and what happens is your B lymphocytes in response produce IgE antibodies, or immunoglobulins. Now again, that only happens to those people who are hypersensitive to it. If this was penicillin, most of us are not going to form IgE antibodies against penicillin. Then what happens is that many of these IgE antibodies not only circulate in our bloodstream, in our body, but many of these IgE antibodies will attach or be taken up by mast cells. So these IgE antibodies are taken up by mast cells. Not only mast cells, but basophil white blood cells. Now, what mast cells and basophils both do is both mast cells and basophils release many chemical mediators of inflammation, most notably histamine. So mast cells and basophils can release histamine. Okay, and so the last comment I'll make, and then I'll show you a diagram. So what's the problem with histamine? Anybody know what effect, you should know, what effect does histamine have, first off, on blood vessels? Dilation. Good, excellent. It dilates blood vessels. So let's just make a note of that. That's going to cause generalized vasodilation. And what effect does histamine have on airways, on the bronchioles? Good. It causes bronchoconstriction or bronchospasm. Bronchoconstriction. So histamine has other actions as well. As I'm going to show you in a moment, it can lead to hives or urticaria. But the two big things that always worry us is a massive release of histamine from mast cells and basophils can lead to generalized vasodilation and bronchoconstriction. We'll see what the result of that is momentarily. Let's just show you a picture. On the next page, on B22, so it says here, the birth of an allergic reaction. So here it shows the B lymphocyte, white blood cells, releasing the IgE antibodies. The IgE antibodies are now circulating in the body. Many of these IgE antibodies are taken up by mast cells and basophils. The second time you're exposed to the allergen binds to the IgE antibodies on the surface of the mast cell, which triggers the mast cell to release a massive amount of histamine. And so this release of histamine in response to the allergen binding to the IgE antibodies on the surface of the mast cell causes this release. Now, another kind of larger view of this shows diagrammatically a mast cell or a basophil white blood cell. Here's the IgE antibodies, which are acting as receptors on the surface of the mast cell. Here's the antigen attaches to the IgE antibodies, and that leads to, as you can see on this side, the release of chemical mediators. And these chemical mediators include histamine, among other things. There's a whole slew of chemicals that are released, kinins, prostaglandins, leukotrienes, and the histamine and these other chemicals affect all kinds of stuff. We've already said that they can cause visceral, it causes the blood vessels to dilate, so we get vasodilation. It actually causes the muscle in the walls of the airways to contract, so we get bronchoconstriction. It causes secretion of mucus by mucus glands. That's wonderful. Mucus secretion. It affects blood platelets, and it affects sensory nerve endings. One of the things that it activates on sensory neurons is it can cause itching. It's also going to cause an increase in eosinophil levels, but I won't go into that. All right, so that's some of the effects of histamine and these other chemical mediators on different parts of the body. Back on the previous page, on B21, so you probably learned 4 major types of antigen-antibody reactions. I'm only going to review with you very briefly 2 of those 4 types. what's called a type 4 delayed onset hypersensitivity reaction, and a type 1 immediate onset hypersensitivity reaction. The problem we have with an allergic reaction is we never know whether the person, whether it's going to trigger a type 4 or a type 1 reaction. There's no way to predict. So what's a type 4 and what's a type 1? In a type 4 reaction, histamine and other chemical mediators are released, and the reaction usually doesn't even appear for about 1 or more days after exposure to what you're allergic to. And the classic thing that happens is urticaria. And urticaria is commonly translated as hives. Is anybody allergic to anything in this class? Anybody in this class? What are you allergic to? A lot. Just not the drugs. Huh?
Latex.
Latex. All right. So here's something, I always point this out. There is one thing I can identify that all of us are allergic to. All of us. It's called poison ivy. So if any of us came in contact with poison ivy or poison oak, so what it causes is an allergic reaction, typically a type 4 allergic reaction where you break out in hives or urticaria. You've seen this with the latex. Your skin swells up, it gets red and bumpy, and it itches. Is that basically right? Now but you can always have to worry that it could be the type 1 anaphylactic reaction as well. Have you broken out in hives or a skin rash? All the time. So that's called a type 4 reaction. And so classically, there could be a low-grade fever, maybe not, could be, enlarged lymph nodes, but classically this bumpy skin where it gets red and bumpy. What the redness is vasodilation. The bumpiness is swelling, edema, localized swelling, and itching and so on. And there's an increase in the T lymphocytes and the eosinophils and the mast cells. Again, I won't get into all the details of that. The more reaction that really frightens us, though, as far as an allergic reaction, is an immediate onset type 1 hypersensitivity reaction. Again, there's no way to predict whether it's going to cause hives or it's going to cause an anaphylactic shock reaction. This can occur when we say immediate onset as opposed to delayed onset. This was delayed onset. It takes about a day or more before you can see it. With an immediate onset, it starts to happen within minutes. And there's a massive release of histamine. When people are going into an anaphylactic reaction, or anaphylactic shock, they get kind of apprehensive. They experience paresthesia. Anybody ever heard that term? You know what that means, paresthesia? What is it? That's a word worth knowing. Huh? A tingling sensation. Tingling. Some people will say pins and needles, prickling. A prickling sensation. So again, if you came in contact with poison ivy, you'd start to feel a prickling sensation, a tingling sensation on your skin where you came in contact with it. So you get this prickling, tingling, pins and needles. Tingling sensation. That's called paresthesia. But the two things that then start to happen are the ones that really scare us. We get the bronchoconstriction or bronchospasm. So as the airways constrict, the person experiences dyspnea. What's that? Difficulty in breathing. Their airways are constricting. They're having trouble breathing. Difficulty or labored pnea means breathing. And the anaphylactic shock, what's causing the anaphylactic shock is the generalized vasodilation. The generalized vasodilation throughout all the vessels of the body lowers the blood pressure. That lowers the blood pressure. And the term that we use for when blood pressure drops is shock. Shock simply means a drop in blood pressure. And if you're wondering, like, and you probably aren't, but just in case you're wondering, well, why, if the blood vessels dilate, does that lower the blood pressure? Think of it this way. When blood vessels constrict, that raises the pressure. I like to use the example of a garden hose. If you have a garden hose and the water is on, right? So water's coming out the hose. If you squeeze the hose a little bit, it increases the pressure, right? In fact, if you put your finger in front of the end of the hose, the water squirts out further. So when you basically constrict a hose or a vessel, the pressure rises. When you let go of the hose, the water will go out not as far. It won't go out as far. There's a drop in pressure. So a dilation of vessels lowers the blood pressure, and that's called shock. So what we've got is two scary things happening. Blood pressure is dropping, and breathing is becoming more difficult. Why is a drop in blood pressure a problem? It's the blood pressure that pushes the blood through the vessels of your body, including up to your brain. So when blood pressure drops, blood flow decreases, including blood flow to the brain. Now, as far as treatment of these conditions, how do you treat these? So in fact, let me just write it right on this page right here. First off, let's talk about treatment of anaphylactic reaction. What do you give? What's the drug that you give for anaphylactic shock? Epinephrine. And typically, now, most offices today are going to have what's called an EpiPen. But in case your office didn't have an EpiPen, or you've ordered it but it hasn't come yet, the dose of the epinephrine that's in an EpiPen that's usually given is you give a 0.5 milliliter, or a 0.5 cc, a 0.5 milliliter of a 1 to 1,000 epinephrine solution. So EpiPen delivers a 0.5 milliliter of a 1 to 1,000 epinephrine solution. If you didn't have it, then you should have in the emergency kit 1 to 1,000 epinephrine. That's the doses that's used. And epinephrine comes in many different dosages. So you always have to verify the dose, unless it's an EpiPen specifically used for that purpose. Now, why is epinephrine so effective in treating this problem? What effect does epinephrine have on airways? It dilates. Epinephrine causes bronchodilation. So that counteracts the bronchospasm or bronchoconstriction. And what effect does epinephrine have on blood pressure? Yeah, epinephrine causes generalized vasoconstriction. And therefore, in general, epinephrine raises the blood pressure. So the reason why epinephrine is the perfect drug, as it were, for anaphylactic shock is it counteracts the two major things that we're concerned about. It dilates the airways, and it constricts vessels, raising blood pressure. So that's what's given. And typically you give a 0.5 milliliter or 1 injection of an EpiPen, and if that doesn't do it, if that's not sufficient, then about 10 minutes later, give another 0.5 milliliter. In the meantime, somebody should have called for an ambulance, and you want to get that patient out of there as quickly as possible. Okay? But you're really doing is not only are you helping the patient get them to the hospital, you are transferring liability. Okay, because you don't want somebody to die in the office. All right? And you never know what's going to trigger an allergic reaction. It might be that over the next 20, 30 years of your professional lives, you never have to exceed this, or you could have it 3 or 4 times. You just never know. Again, gloves. Some people are allergic to gloves. They're just allergic to, they can be allergic to lidocaine, they can be allergic to anything. So you just never know. In terms of the delayed onset reaction, so what do they give for that? So when we're dealing with hives and this kind of skin rash, this delayed onset, so the most common things that are given are an antihistamine, And antihistamines are even available over the counter. Benadryl, which is diphenhydramine. And so they have both topical Benadryl, where you can apply it topically or spray it onto the skin. And of course, there are antihistamines you can swallow. That's Benadryl. But what even works, I think, even better than the antihistamine is a corticosteroid. And while many corticosteroids do require prescription, there's a corticosteroid that is available over the counter called Cordaid, which is hydrocortisone. And corticosteroids also reduce allergic reactions. That's why people who have allergies will sometimes squirt Pronase or some corticosteroid up in their nose to reduce allergic rhinitis and so on. So that's what's usually applied topically. You can also take it as a pill. So that's how you treat those. On page B23, what other types of adverse reactions are there? There are idiosyncratic reactions. You'd say, what's that? Unexpected, strange, paradoxical reactions. And sometimes we kind of know they're going to happen. I'll give you a couple of examples. When we give CNS depressants, such as Ambien, which is something to help people sleep, giving children a CNS depressant when we give a CNS depressant to children, it actually has a stimulating effect. It stimulates them. So how many parents have discovered this is they were going to take a long airplane flight. They knew that they usually take an Ambien to help them sleep. So they took a little tiny piece of an Ambien, and instead of, so they wanted the kid to be able to sleep on this 17-hour flight. The next thing they know, they're running up and down the aisles because they're wired. Because it affects children commonly, paradoxically, the opposite way. Interestingly, a CNS stimulant to a child, let's say as an example, dexedrine, actually calms them down. And that's why kids who have ADD, who are like crazy, what do they give them? Adderall, dexedrine, Ritalin. These are CNS stimulants. And that actually calms them down. Now, if you're wondering, so why in children do we see the opposite effect? Here's the simple answer. Is the brain of a child fully developed? No. And why some kids, and we'll talk more about this at another time, why some kids may tend to be have ADD and so on, and other kids don't, is simply because not all children's brains mature at the same rate. Some mature faster and some mature more slowly. In general, boys are more likely to have ADD. Girls can too, but usually it's boys. Why? Because they mature slower in everything. They physically mature later than girls, right? And they emotionally mature later than girls, and their brain matures slower than girls. So they're just a 7-year-old boy is like, running up and down, and a 7-year-old girl might be able to sit in class all day long. A 18-year-old woman is thinking about life, and an 18-year-old guy is belching and having belching contests with his friend. All right, another type of adverse effect is a teratogenic or teratogenic effect. And teratogenic refers to effects on the fetus. So obviously, I mean, the general concept is, as you know, that when women are pregnant, basically doctors don't want to prescribe anything for them for fear that any medication they take might possibly harm the baby. But in fact, drugs are assigned a category by the FDA, the Food and Drug Administration, and there are 5 categories, A, B, C, D, and X, based upon the teratogenicity of the drug. So let me remind you that last week we talked about thalidomide and how that was severely teratogenic on the baby. So what is a category A drug? Category A means essentially it's totally safe. It is really anything that's category A, the doctor would prescribe or recommend, not a problem. Basically, that's like vitamins. So in fact, all women usually during pregnancy, in fact, do take vitamins. Category B. So these are not likely to cause any harmful effect on the baby, but it's not as safe as a vitamin, and that includes lidocaine and Tylenol and penicillin. And in fact, all those who are commonly given to women during pregnancy. If a woman gets sick, who's pregnant, they'll give her penicillin. She could be given pain medication, take Tylenol, and so on. Category C, we're starting to get a little bit worried that it might have some of harmful effects. Notice that includes mepivacaine and procaine and epinephrine. And the reason why you'd say, well, what would epinephrine do? Well, it speeds up heart rate. And so you get a little fetal heart. And that's probably not going to cause any permanent damage, but it could stress the heart. And then category D. Okay, by the time we get to category D, you don't want to give these. Well, again, you don't want to, as you move down this list. That includes tetracycline, which we know will affect bones and teeth. And Valium, nitrous oxide. These are just some examples. And as you look up drugs, all drugs are assigned a teratogenic FDA category. If it's X, we know for sure it absolutely will harm the baby. And so that includes, not only would it include what we spoke of, thalidomide, but I gave another example, DES. DES is, anybody know? Diethylstilbestrone. And diethylstilbestrone is an estrogen. And in fact, you might have heard stories where women were given in years past estrogen during pregnancy, and it did affect their baby. It actually, their baby daughters had an increased risk of developing cancer. Anybody ever hear anything like that? So in general, I didn't list it, but in general, hormones are not given to women who are pregnant. The only hormone that's usually given, or could be given, is progesterone, because progesterone is naturally secreted by the ovaries of a woman when she's pregnant. That maintains vascularization of the endometrial lining of the womb. But any other hormones, not only would the hormone affect the mother, it would affect the baby. And so hormones in general are category X, usually. That would include like cortisone and prednisone and so on. All right, another category of adverse effect is carcinogenic effects. Well, in fact, I was just mentioning diethylstilbestrone had the effect, this estrogen, of increasing the risk of cancer in the daughters that women gave birth to. I might just mention that, interestingly, sex hormones, and that includes testosterone and estrogen, both male and female sex hormones, increase the growth of a cancer. They promote the growth of cancers. Now, what I'm saying here is they promote the growth of a cancer. They don't cause the cancer, but they promote the growth. Let me put it this way. Estrogen stimulates the growth and multiplication of cells in certain parts of a woman's body. growth of the breasts, growth of the uterus, and so on. If that estrogen will not only promote the growth and multiplication of normal cells in those parts of the body, but also any cancer cells that are there. So if there are cancer cells in the breast, in the uterus, including the cervix, estrogen promotes its growth. It doesn't cause a normal cell to become transformed into a cancerous cell, but it will promote or stimulate growth of all cells in those targets where estrogen affects. And so this is actually known as, it's not called a carcinogenic action, but an epigenetic action. But it promotes the growth. So this is why, in fact, when women have breast cancer, uterine cancer, ovarian cancer, and so on, they actually may give drugs that block the action of estrogen. These are known as anti-estrogenic drugs. Or they might even give, interestingly, androgenic or masculinizing drugs to the woman. Has anybody ever heard of this? Conversely, in the case of testosterone, testosterone promotes the growth of cells, both normal and cancerous cells, for example, in the prostate gland of a guy. So testosterone, if a guy has a prostatic cancer, which is one of the more common cancers in men, they will give an anti-testosterone drug. They will block the testosterone receptor sites because testosterone is actually stimulating the growth and multiplication or proliferation of the prostatic cancer. So that's the sex hormones. Drug dependency. What is the difference between physical dependency and psychological dependency? Let me start with the second. Frankly, psychological dependency, I don't even consider a real concern, or it's a concern for everything. Essentially, somebody can become psychologically dependent upon anything. Anything. For me, it's Chunky Monkey ice cream. You know, I have to have Chunky Monkey ice cream every day, or I'm like depressed. So you can become habituated or used to anything. If somebody takes a Tylenol, they can become psychologically dependent upon taking their Tylenol every day. So that's just psychological dependency or habituation. It becomes a habit. What is of greater concern, though, is physical dependency. Now, how do you know physical dependency has occurred? The definition of what that physical dependency has occurred is that if somebody stops taking or stops doing something, do they go through withdrawal, physical withdrawal? I don't mean psychological craving. Literally changes in their blood pressure, in their heart rate, in their physiology. So physical dependency will result in withdrawal. Withdrawal symptoms when they stop taking that medication. It will result in withdrawal symptoms when the drug stops being taken. There literally has been physiological changes that have resulted from taking this drug repeatedly. Now, usually the withdrawal, the physical withdrawal, is the exact reverse of what the drug causes. Let me give you an example. Consider a narcotic drug, a narcotic pain reliever like codeine. So if somebody has developed a physical dependency for a narcotic drug like codeine or morphine or something like that, what does codeine do? Codeine and all narcotics make somebody sleepy. It relaxes them, it lowers their heart, slows their heart rate, it lowers their blood pressure, and it even causes them to get constipated. Does that make sense? Mm-hmm. Narcotic drugs make you relax, they make you sleepy, they lower your blood pressure, they even make you constipated. If the person has developed a physical dependency to that narcotic drug, when they stop taking it, they can't go to sleep. They're wired. They have insomnia, they can't sleep, their blood pressure goes up, their heart rate goes up, and in fact they develop diarrhea. In other words, their body has gotten used to the presence of this drug, and they're physiologically only, quote, normal when they continue to take the drug. When they stop taking it, their body now goes in the reverse direction of what the drug causes. So whatever the drug tends to cause to happen, if they have developed a physical dependency, when they stop taking it, their body goes too much in the opposite direction. It has gotten used to the presence of that drug. And there are many, many drugs, not all, but many drugs that do cause physical dependency. In general, I should say even in general, all of the drugs that do cause physical dependency are regulated as controlled substances by the Drug Enforcement Administration. On page B24, the last category of adverse effect is called an iatrogenic effect. And I think you've all learned that word before on B24. What does that mean? You did it. You caused the problem. So obviously if one gives a medication and that results in a problem, whatever that problem is, that adverse effect, and it was due to your administering of that medication, that's called an iatrogenic disease. Now, this is not usually a problem in dental hygiene because you're not prescribing medications and so on, but in general, in the medical world, iatrogenic disease is a big deal. Just as an example, here's an easy one that's iatrogenic, is death from surgery. So they think that 12,000 people a year, they've estimated, die each year from unnecessary surgery. That's not taking a medication. In the hospital, 20,000 deaths per year from medical errors for medical errors in general. And medication errors, specifically drug errors, that was the top number, was 7,000 deaths per year. It is not uncommon for patients in the hospital to be on 7 medications simultaneously. 7 medications is pretty typical. So these are studies that have been done. All right, the last aspect to toxicology of analyzing harmful effects produced by drugs is how do we evaluate the relative safety of a drug? So the first term that I've listed, I think many of you have heard of. It's called the LD50. Has anybody ever heard that expression, the LD50? Let me put it in this context. The LD50 stands for the lethal dose in 50% of animals. Now, here's the context that you've heard of it. You have heard of animal rights groups like PETA who break into research labs because they do experiments on animals, including LD50 studies. Before the FDA will approve any drug or even cosmetic, they have to go and find out, they require that they do testing on 2 species of animals to find out what dose will kill half the animals. You'd say, and they literally, the study requires that they kill animals. They have to give increasing doses to see. You'd say, why do they want to know that? They want to know what's the margin of error, safety, between the therapeutic dose that's normally given and the dose that's fatal. Is it just a matter of a few milligrams difference, or is there plenty of separation between the therapeutic dose that's given and the lethal dose, the dose that kills? Obviously, we can't do that lethal dose study in humans. We can't go and give different doses to see which dose kills people. So the only thing we can do is do these animal studies and extrapolate based on the dose that kills the animals, what dose, therefore, would result in death of us. Does everybody follow that? Mm-hmm. So this is required by the FDA. If you develop a new drug and you say, well, okay, so this is the dose that works, this is the dose that has benefit, the FDA says, and what dose could result in death? And if you say, I don't know, they say you have to find out what dose would cause death in that person. So look, think of a narcotic pain reliever. Narcotic pain relievers are really important. Imagine having a dental procedure and no Vicodin. But you've got to know the dose that hydrocodone will cause somebody to die. So this is called the LD50, and the lethal dose in 50% of the test animals. And then once they know it for the animal, obviously they extrapolate based on weight and other factors. If they did that on, let's say, a mouse, they did it on a dog or whatever, so then they extrapolate, since the mouse is this big and a human is much bigger, then the corresponding dose that would kill us would be correspondingly proportionately larger compared to the size of that little mouse. So this way we can also compare different medications. We may find that the LD50 of two different pain relievers differ, and one drug might be safer because it takes a much higher dose to cause the death in somebody than another drug. There's a number of, another concept, there's a whole bunch of these ways they analyze this, and incidentally, related to these LD50 studies, for cosmetics, for example, mascara, they commonly use bunny rabbits. And because the eyes of bunnies are very sensitive, and they want to know if the mascara gets into their eyes, at what dose will that mascara cause a great deal of redness and irritation to the eye? So, like, I'm not saying it's nice to do these things, but imagine you putting mascara or eyeliner on and it causing tremendous irritation and maybe even injury to the eye. So you would want to know that, and you can't really do that on people. It really has to be done on animals. So that's where you hear about these animal rights groups breaking into research labs. I do want you to know what the Therapeutic Index is. The Therapeutic Index, or TI, is the ratio of the LD50 to the ED50. It basically compares what dose is therapeutically the effective in 50% of the animals, and therefore correspondingly in humans, and which dose would kill 50% of the animals, and correspondingly people. Let me give you, make up an example to show you what I mean. All right, let's say that we had a drug, and the ED50, the effective dose, was, let's say, 60 milligrams. That's the recommended dose for people to take 60 milligrams. Maybe it's codeine. Let's say that codeine, and I haven't looked it up, but let's say the LD50 is, let's say, 6,000 milligrams. And it might be less. So what's the ratio, what's the margin of safety that we have between the dose that's effective and the dose that's lethal? So 60 goes into 60,000, I can cross out a 0 here and here. 6 goes into 600, 100. So what that means, if I did that right, is that the dose that will kill is 100 times greater than the dose that's used therapeutically. Does everybody follow that? Now what if we took another drug, not codeine, but something else, and it had a therapeutic index of, say, 20. That means the dose that would kill is only 20 times greater than the dose that's therapeutically used. So that would mean that this drug would be a better choice in terms of safety than a drug with a therapeutic index of 20. 20 is a smaller difference between the therapeutic dose and the lethal dose. The bigger the therapeutic index, the more margin of safety you have. Imagine somebody who took an overdose of a drug. If the drug is really toxic or lethal, then it might just be a few extra pills and they would die. And you might ask, well, really, Professor Fink, are there really drugs that the FDA has approved where the difference between the therapeutic dose and the lethal dose is a small difference? Yes. digitalis or digoxin. It's also known as digitoxin. Digitalis, a very important drug, has a very narrow margin of error or therapeutic index. I might also mention that almost all anti-seizure drugs used to control epileptic seizures have a very narrow therapeutic index, because these are drugs that are affecting electrical activity in the brain. And when you start trying to slow down electrical activity in the brain, if you take too much, it slows it down completely. And so the therapeutic index on anti-seizure drugs is very small. It's a small therapeutic index. Now, I do want you to know therapeutic index, but you know what? Just as a criticism of it, this is comparing the dose that is effective in 50% of the people with the dose that's lethal in 50%. You know, I don't want to know the dose that kills 50% of the animals or 50% of the people. I would like to know what dose would kill 1% of them, which is going to be a much smaller number. It takes a higher dose to kill half the animals or half the people. I'd like to know what dose would kill 1%, because some people are more sensitive to drugs than others. So in fact, on page B25, the certain safety factor compares the difference between the LD1 and the ED99. That's a comparison of the dose that is effective in 99% of the people versus the dose, the lethal dose, the dose that's lethal in just 1% of them. That's going to be a much smaller difference, because some people are very sensitive to drugs, and they might fall in that very first percent that would die from a certain dose. So as I wrote, it is generally best to use those drugs that have wider, larger margins of safety between the therapeutic dose and the lethal dose. The last thing I want to do is, in terms of introducing our pharmacologic principles, is to show you how we use a patient's medical history. And I think you've done this with your patients, but let's take a look at page B27. B27. And I thought this is a particularly pretty good medical questionnaire. And we'll kind of walk our way through it. And I'm looking at it mostly from the perspective of medications. Obviously, here at the top, this is where the patient would write in their name and so on. The gender of a person is important, because we know that from a perspective of medication, females are more sensitive to drugs than males. They metabolize drugs at a slower rate than guys do. The age of a person is always relevant. We know that children and elderly metabolize drugs at a slower rate than people who are young adults. The height and weight are factors, because we've learned that you have to adjust the dose of the drug based on the size of the person. If they are a bigger person, they need more of the medication. If they're a petite person, they need less of the medication. You don't give everybody the same dose. There's that Clark's rule for adjusting dosage. Occupation is interesting, because we know that certain occupations have typical occupational risks, diseases, disorders that are associated with certain occupations. If somebody is an airplane mechanic, he's probably exposed to a lot of sound from those jets, and is probably more likely to develop hearing loss, just as an example. But there are people who work, for example, some people work in an environment where they're more exposed to X-rays. Oh, that could be you, than other people. Again, it's usually not a problem. You're doing it at a very safe level, but you certainly don't want to stand in front of X-ray machines any more than you need to. So there are various types of occupational hazards. All right, let's go through each of these. And what I liked is the way the questions are phrased. The first question is, are you in good health? So most people are generally going to say yes, except for your hypochondriacs. The hypochondriacs are the people who complain about everything. So in fact, a hypochondriac, when completing this medical history, will ask for additional paper to write down more stuff. Does anybody run into people like that? All right, so they've got everything wrong, and they're going to make sure you've heard it all. Now, what I liked is after they asked, are you in good health? And most people will say yes. So then they followed up, well, has there been any change in your health in the past year? Sometimes once you say it that way, somebody will say, you know, now that you mention it, I've started to notice this problem. When was the last physical exam? You know, some people haven't had a physical examination, a general physical, in 15 or 20 years. So we don't know what they've got. Who's the physician? Because sometimes you have to contact them to basically ask questions about a procedure. And what you're really doing is not only getting medical advice from the physician, you are transferring liability. Because if they say, okay, then if anything goes wrong, you consulted with the physician and got their approval. All right, so that's done. That's based on the broad concept called CYA. What's that? Cover your ass. All right, so have you had any serious illness or operation, and for what? And have you been hospitalized in the last 5 years? Okay, and then they zero in on some diseases. So any history of rheumatic fever, rheumatic heart disease. That's certainly relevant from a dental perspective. Congenital heart lesions, also something that you should be aware of. Cardiovascular diseases, heart trouble, heart attack, coronary insufficiency, coronary occlusion, high blood pressure, arteriosclerosis, stroke. These are not the same as rheumatic heart disease. This has nothing to do with autoimmune, but just knowing about their blood pressure issues. The problem is, when most average lay people read these words, they don't even know what they mean. They don't know the difference between coronary insufficiency and high blood pressure. They don't know the difference between arteriosclerosis and a stroke. So that's the first problem. So then they followed up. Well, do you have any pain in your chest upon exertion? What would that be indicative of? What do we call that if somebody has pain in their chest? Angina or angina pectoris. As we will be reviewing with you, angina, pain in the chest, is associated with coronary artery disease. They've got clogged up coronary arteries. We'll remind you of that. So they may not have been to a doctor. Maybe they don't know what angina even means, but they have symptoms of angina. Are you ever short of breath after mild exercise? Now, this is not asthma, because if asthma, you start to get short of breath when you even begin exercise, not after the exercise. This is actually associated with congestive heart failure. So people who have what's called congestive heart failure, where their heart is not pumping the normal volume of blood, commonly develop this SOB, shortness of breath, because blood starts to accumulate in their lungs. And so they get pulmonary edema. This is really pulmonary edema, which is associated with congestive heart failure. We'll be reviewing more of this kind of pathophysiology. Do your ankles swell? Well, in this case, we're not talking about having arthritis, because if you had arthritis, it's not going to be limited to your ankles. This is high blood pressure. High blood pressure. Because when people have high blood pressure, fluid squirts out of their blood vessels, and they get swelling or edema. And the reason why the edema is most noticeable in the ankles is because gravity pulls the fluid, this edematous fluid, down towards the feet. I know that I've driven along up Fairfax, and there's a lot of older people who live on Fairfax, and as I'm driving, I'll see these elderly people with their carts. and I look at their ankles and I see swollen ankles. Have you ever seen this? And I'm thinking high blood pressure, high blood pressure, high blood pressure. Okay, that's the classic symptom. Do you ever get short of breath when you lie down or sleep? This is, again, pulmonary edema associated with congestive heart failure. Allergies. All right, so some people know they have allergies. Some people don't know they have allergies. Asthma or hay fever. And incidentally, asthma and hay fever are associated with having allergies. Hives or skin rash, characteristic of allergies. So this is all dealing with allergic problems. Fainting spells or seizures. All right, so this could be epilepsy, could be other problems as well for fainting. Diabetes. Now you can ask a lot of people, would you have diabetes? No. Well, have you been to the doctor? When was your last visit? About 10 years ago. So maybe they do have diabetes. So they zeroed in, no matter what they say, whether they have diabetes or not. So they asked, do you have to urinate more than 6 times a day? Are you thirsty much? Do they have bleeding disorders, or do they tend to be a bleeder? Are they anemic? Have they had any history of tumors? And then it says, number 11 on page B28, are you taking any medicine right now? And of course, this is again where you tend to see some people where they'll say, nah, I'm not taking anything, even though they might be. And then there's other people who want you to know every single thing that they're taking. Anyhow, they zero in after asking, well, are you taking any medication? So number 12 follows up, because maybe they didn't think or remember that maybe they are taking antibiotics right now. Maybe they're taking anticoagulants or blood thinners. Maybe they're taking medication for high blood pressure, corticosteroids, tranquilizers, aspirin, medications for diabetes, digitalis, which is used for heart problems, nitroglycerin, which is used to control angina pectoris. And then number 13, do you have any history of allergic reactions to any of these medications? Number 14, have you had any serious trouble associated with any previous dental treatment? Actually, if somebody says, yeah, you might send them to another hygienist, because if they say that they always have a lot of problems with dentists and dental hygienists, they're probably a troublemaker. But anyhow, number 15, do you have any disease or condition or problem not listed above? And again, that's when the hypochondriac wants additional pieces of paper so they can write down additional stuff. And obviously, in the case of women, this is an important question here. Are they pregnant at that time? Okay, anyhow, those were some examples of, I think, pretty good, pretty thorough medical history or health history for a patient.